World War II was one of the defining events of the 20th century and still has considerable relevance to the world today. However, while all eyes were on Europe and the Pacific, on the other side of the world in a small laboratory at the Wisconsin Alumni Research Foundation, a scientist was trying to isolate the anticoagulant factor from the spoiled clovers that were killing the local cattle. What he found was bishydroxycoumarin, and when he brought it to his colleagues, he said, Bistroxamin, what if we just name it after ourselves instead? And so they did. But then let's add a rin to the end of it so it sounds more science-y. And so they did that too. Warfarin was initially introduced as a rodenticide in 1948, and it even still sometimes is used for this purpose. In the 1950s, it was first used as an antithrombotic agent in humans. Today, well, it's one of the most widely prescribed drugs in the world. Warfarin! What is it good for? Absolutely. Well, a lot, actually. Let me tell you. Specifically, it blocks vitamin K epoxide reductase, the liver enzyme responsible for turning vitamin K into its active form. This means that the vitamin K-dependent clotting factors 2, 7, 9, and 10 cannot function properly. The thing to keep in mind here is that this misstep in the carboxylation process occurs at the time of protein synthesis. Warfarin does not affect the structure or function of existing coagulation factors. So, while the heparin and thrombin inhibitors from our previous sketch were able to immediately interrupt the clotting cascade, warfarin instead exerts a delayed anticoagulant effect. Let me show you what I mean. Vitamin K serves as a factor for the enzymatic activation of clotting factors. So think of it as the vitamin that stops bleeding. K for coagulation, if you will. Just like a field medic stopping the bleeding of this wounded soldier. And as a little extra reminder, we've turned the medic logo into a cool VK symbol for vitamin K. Vitamin K works by aiding in the gamma carboxylation of the clotting factors 2, 7, 9, and 10, as well as protein C and S. This gamma carboxylation step is necessary for these factors to function in the coagulation cascade. In this sketch, coagulation factors will be represented by soldiers. So we've made our vitamin K medic aiding these coagulation fighters by applying a gamma carboxylation bandage. Notice that the gauze is conveniently gamma-shaped. Specifically, the vitamin K-dependent gamma carboxylation is important for the synthesis of clotting factors 2, 7, 9, and 10, designated by the Roman numerals on the soldier's jacket. Let's meet the men, shall we? Taking the lead is the second regiment, the Angry Throm Beavers. Remember from our heparin sketch that the fibrin-activating beaver is our symbol for thrombin, or factor 2. And you have to admit, those throm beaver teeth look just like the Roman numeral 2, don't they? Up next, looking a little worse for wear, is the 7th Brigade, the 7 Deadly Sins. Right behind him, the 9th Regiment, better known as the 9 Lives. I mean, just look at that vicious cat symbol. Bringing up the rear, the factor 10 Fox Brigade. Remember the X in Fox whenever we talk about factor 10. These are your vitamin K-dependent clotting factors, each wearing that gamma carboxylation bandage and ready to go. Now, an exam question may mention that this carboxylation is occurring at the glutamic acid residue on these factors. So, we've included a GL symbol on our GI in the lead of the pack, just in case. Okay, after serving as a cofactor for this carboxylation reaction, vitamin K becomes oxidized into an inactive vitamin K epoxide. So before activating some more clotting factors, it first goes back to the liver to get reduced back to its active state. The enzyme that reactivates vitamin K for another round of coagulation is vitamin K epoxide reductase, or VCOR. Let this VCOR supply ship remind you of this liver enzyme, as our vitamin K medic gets reactivated with some new supplies, ready to throw on some gamma carboxylation bandages onto a new round of coagulation fighters. However, besides coagulation factors, vitamin K is also responsible for carboxylating protein C and S, endogenous factors that normally exert an anticoagulant effect. Proteins C and S will be represented by the corporal and sergeant in the background, with helmets labeled C and S, respectively. Notice that instead of charging forward, they cautiously hold their coagulation fighters back, highlighting their anticoagulant effects. So remember, the gamma carboxylation activity of vitamin K contributes to both coagulant and anticoagulant forces. All right, so how does warfarin act as a vitamin K antagonist? Well, remember that VCOR reducing enzyme that reactivates vitamin K? Warfarin inhibits this reaction, thereby preventing the inactive vitamin K epoxide from returning to its active form. Think of warfarin then as this warhead, shaboom! that has just taken out the VCOR supply ship, resulting in inactive and incapacitated vitamin K medics. No VCOR, no functional vitamin K. No functional vitamin K, and you've got yourself some dysfunctional coagulation factors that are biologically inactive. I want to reiterate, though, that the onset of action is not immediate. In our previous sketch, the heparins and thrombin inhibitors were able to immediately inactivate clotting factors and halt the coagulation cascade. These are the agents you want when treating acute thrombotic events. Warfarin, on the other hand, merely inactivates vitamin K so that new coagulation factors can't be synthesized. Some previously synthesized functional clotting factors are still floating around, though. Thus, the ultimate anticoagulant effect of warfarin is delayed until these active factors are cleared from the circulation. Factor VII is the first coagulation factor to go down, as depicted by our wounded Factor VII fighter in the foreground. In fact, this clotting factor has a half-life of about 6 hours, so you'll have to wait at least that long to get any kind of anticoagulant effect from warfarin. This delayed onset of action, then, is kind of like the delayed explosion of this warhead here that's just hit the sand. In reality, there is an 8 to 12 hour delay in the action of warfarin. Not only that, clotting factor II takes a long time to leave the circulation, and the full clinical effect of warfarin does not occur for at least 3 days after starting new treatment. This soldier then has plenty of time before that thing goes off. So he sits back and tosses in a bit more into his mouth. This is to highlight the oral administration of warfarin. Not only is it taken orally, but it has a pretty long serum half-life as well, lasting 36 to 42 hours. This allows once daily dosing for long-term anticoagulation. Whenever we want to show extended drug half-life, we'll include a long tapering flag, evoking an image of the extended and lingering serum concentrations of warfarin. Warfarin administration can be challenging because its therapeutic range is narrow, and dosing is affected by many factors. Therefore, careful monitoring is required to determine the degree of anticoagulation. For the vast majority of patients, monitoring is done using prothrombin time, or PT. Notice that we've highlighted the P and T in the word paratrooper. This parachuting soldier is an especially convenient symbol for PT monitoring because PT measures the function of the extrinsic coagulation pathway. So just think of this soldier parachuting into the scene extrinsically. The function of the extrinsic pathway is a useful measure of warfarin activity because the main component of the extrinsic pathway is factor VII. Recall that factor VII has the shortest half-life of all the coagulation factors. Hence, we've made our factor VII soldier prematurely out of commission because of his injuries. Not only that, we've included the symbol of his battalion, the 7 deadly sins, on the paratrooper who comes to his aid. A little extra reminder that warfarin prolongs PT because of inhibition of factor VII specifically. The therapeutic range for warfarin therapy is defined in terms of the International Normalized Ratio, or INR. Just think of INR as a special international reference standard for reporting PT, and in this scene, INR will be represented by the intercom radio worn by our extrinsic paratrooper. INR is normally around 1 in you and me, with warfarin therapy sending it to higher values. The recommended INR for prevention and treatment of thrombotic diseases is 2 to 3. Hence, we've made the intercom radio tuned somewhere between 2 and 3. This will be the most common therapeutic range emphasized on the exam, though there are instances when higher INR is targeted, such as patients with certain artificial heart valves or medical conditions conferring increased thrombotic risk, when INR levels up to 3.5 may be preferred. Alright, there are numerous clinical uses of warfarin. I mean, this drug has been around for a long time. It's cheap, effective, and doctors have extensive clinical experience with it. In fact, warfarin is the most commonly used agent for long-term anticoagulation to prevent thrombotic disease. On the exam, clinical scenarios will likely involve patients with AFib. Remember that AFib is classically described as an irregularly irregular rhythm with no P waves. At Sketchy, our recurring symbol for AFib will be a monitor showing a heart with a little irregular static trace across the screen. Think of AFib as an erratic signal coming in and out, transmitted from your atria to cause your ventricles to beat irregularly. During this irregular rhythm, abnormal blood flow through the heart increases the risk of developing a clot, which can embolize and cause a stroke. These patients therefore require long-term anticoagulation prophylaxis. So, as this allied ship offshore monitors that erratic incoming radar signal, keep warfarin in mind as your first-line agent for long-term anticoagulation in AFib. Warfarin is also commonly used as treatment and prophylaxis of DVT and resultant pulmonary thromboembolism, or PE. Recall from our heparin sketch that DVT usually involves the deep veins of the leg, including the iliac, femoral, and popliteal veins. So we've made our warfarin warship patrolling the iliofemoral river. It's important to keep in mind, however, that in this setting of DVT, with or without ensuing PE, acute treatment involves immediate administration of IV heparin, or one of the other indirect thrombin inhibitors from the previous sketch. A continuous heparin drip, for instance, can be started to reduce extension of the clot and minimize the risk for PE. Remember, warfarin has a delayed onset of action because you have to wait for all those clotting factors to leave your system first. So, acute anticoagulation therapy is started first, usually for 5 to 10 days, before transitioning to a long-term anticoagulation agent such as warfarin. Patients usually take warfarin for about 3 to 6 months following the diagnosis of DVT to ensure that the thrombus does not grow and to let the body naturally resorb the clot. One thing to watch out for: pregnancy. Warfarin crosses the placenta readily and can not only cause a hemorrhagic disorder in the fetus, it can also prevent important carboxylation reactions in fetal bone, resulting in abnormal bone formation. Warfarin should never be used during pregnancy, so we've brought back our recurring sketchy symbol, the teratogenic tarantula. Instead, keep that baby happy with heparin. Another adverse effect to watch out for is warfarin-induced skin necrosis, thought to be due to a transient hypercoagulable state that can occur during the first few days of warfarin therapy. I know what you're thinking. Hypercoagulable? You're a liar. Lying. Lies. First of all, calm down, okay? Just calm down. You can't fight in here. This is the warfarin room. Secondly, remember that the overall anticoagulant effect of warfarin is due to its inhibition of the vitamin K-dependent gamma carboxylation of coagulation factors 2, 7, 9, and 10. However, warfarin also decreases carboxylation of protein C and S, which normally exert an anticoagulation effect. Protein C specifically has a short half-life, similar to the half-life of factor 7. So, its anticoagulant activity is quickly reduced after initiation of warfarin therapy. Take a look. Not only have we illustrated our factor 7 fighter down, now our protein C corporal has been taken out by a warfarin warhead as well. He had initially been holding back his clotting fighters, but now they charge ahead, ready to coagulate the enemy. Protein C activity drops about 50% within the first day of warfarin treatment. During this time, the vitamin K-dependent clotting factors with longer half-lives, 2, 9, and 10, continue to exert an unchecked procoagulant effect. This hypercoagulable state can manifest a few days after starting warfarin therapy. It involves frank infarction or necrosis of the breast, fatty tissues, and extremities, kind of like the dark black patches of soot covering our injured protein C corporal. For this reason, overlapping co-administration of heparin, the so-called heparin bridge, is commonly started at the same time as warfarin therapy. So we've brought our heparin hunters back to the scene, this time responsible for holding back those unchecked clotting factors as they patrol the bridge above. A heparin bridge, if you will. Heparin or a related agent is usually overlapped with warfarin for a few days until warfarin has time to take full effect. I also want to note that the risk of warfarin-induced skin necrosis is increased in patients with a pre-existing protein C deficiency. In fact, as many as a third of patients who develop these lesions will also have an underlying hereditary protein C deficiency. All right, keep in mind that skin necrosis is a rare side effect. Warfarin is more commonly associated with an increased risk of bleeding, just like any anticoagulant. On the exam, keep a few important clinical scenarios in mind when a patient will have increased risk of bleeding while on warfarin. For instance, maybe your patient has been inadequately monitored and they are sitting there with an INR that's too high. Or maybe your patient is on another medication that affects bleeding, such as an NSAID, an antiplatelet agent. You know what? This is a vitamin K antagonist we're talking about here. So maybe your patient has poor vitamin K intake or liver disease, and they already aren't producing very many clotting factors. Whatever the case may be, one of the most concerning complications is the precipitation of intracerebral hemorrhage, which can be fatal. In the presence of any clinically significant bleeding, first things first, discontinue warfarin. Can't we also just load them up with vitamin K? Yep, it can even be administered IV. But vitamin K merely reboots the synthesis of clotting factors, and this can take a while before it has any effect. Administering vitamin K is kind of like sending in a new team of vitamin K medics. Yeah, they'll get there eventually, but just look at them. They're still pretty far away. I mean, we didn't even take the time to add any detail to them. They're just a couple of ominous, out-of-focus guys. For immediate warfarin reversal, you have to directly administer clotting factors. One way to do this is with fresh frozen plasma, or FFP. FFP has all the factors you need to immediately restart the clotting cascade to achieve rapid hemostasis. Think of FFP as this FFP fighter pilot, providing immediate air support to our coagulation fighters. The important thing here is replenishing factors, and there are actually many other ways to do that, including prothrombin concentrates, recombinant factor 7, and recently approved in the US, a 4-factor concentrate containing factors 2, 7, 9, and 10. All of these get your clotting fighters back on the battlefield for rapid warfarin reversal. All right, just one more thing I want to mention before it's all quiet on the warfarin front. Lots of them, actually. Numerous drugs are known to augment the effects of warfarin, either by altering the cytochrome P450 system, protein binding, or GI absorption. On the exam, emphasis is usually placed on drugs that interact with the liver's cytochrome P450 system because warfarin elimination occurs primarily through hepatic metabolism. Our recurring symbol for cytochrome P450 is a CYP450 license plate attached to a chrome bumper. When drugs activate cytochrome metabolism, we'll associate this chrome bumper with a car revving its engine. When drugs inhibit cytochrome metabolism, this CYP450 license plate will be attached to a rundown, dilapidated vehicle. In this scene, we've attached our recurring CYP450 license plate onto a chrome tank, running over a warfarin warhead to remind you that warfarin is a substrate of cytochrome metabolism. In other words, drugs that increase P450 metabolism, such as rifampin, phenobarbital, and phenytoin, increase warfarin metabolism, diminishing its effects. Drugs that decrease P450 metabolism, such as some antibiotics, antifungals, and SSRIs, decrease warfarin metabolism, enhancing its anticoagulant activity. So when a patient comes in and all that warfarin you've given them just isn't working, think of the numerous drugs out there that can augment warfarin absorption or metabolism. All right, let's sum up this coagulation conflict in a few important points. Warfarin is a vitamin K antagonist. Specifically, it blocks vitamin K epoxide reductase in the liver so that vitamin K can't return to its active form. So, since the vitamin K medic can't return to the V-core ship to resupply, the vitamin K dependent fighters 2, 7, 9, and 10 are not gamma carboxylated and not synthesized properly. The key word here is synthesis. Warfarin has a delayed anticoagulant effect because you still have to wait for active coagulation factors to leave your circulation. The first factor to go down is factor 7. Hence, our factor 7 fighter is on the ground wounded. However, protein C has a short half-life as well. Along with protein S, protein C is an endogenous anticoagulant, and its inhibition during the first few days of treatment increases risk for warfarin-induced skin necrosis, a transient hypercoagulable state involving frank infarction of superficial tissues, much like the black patches of soot covering our injured protein C corporal. For this reason, the initiation of warfarin therapy is overlapped with the heparin bridge. Just think of our heparin hunters holding back those unchecked clotting fighters who rush past their fallen protein C comrade. At the bottom right of our sketch, a hungry soldier reminds us that warfarin is an oral anticoagulant. And that teratogenic tarantula should remind you that warfarin crosses the placenta and it's unsafe in pregnancy. Warfarin is monitored using PT or INR. Just think of our PT paratrooper flying in with that INR intercom. This is a measure of the extrinsic coagulation pathway. Hence, he enters the scene extrinsically. Look for an INR target of about 2 to 3 when treating most thrombotic diseases. The clinical uses of warfarin are numerous, but on the exam, they'll likely focus on AFib. So remember that irregular static trace across our atrial sonar screen. One of the most concerning complications is the precipitation of intracerebral hemorrhage. If you want to reverse warfarin, just load them up with vitamin K. However, if you want to reverse warfarin quickly, you gotta give them factors. So send in the fresh frozen plasma fighter pilots. Numerous drugs interact with warfarin. Remember that it is a substrate of cytochrome P450 system in the liver. Warfarin not having the effect you want? Check the medication list. The patient's probably on a drug that's revving up that CYP450.